Hello everyone. So today class we are going to discuss the rest of microbiology. First of all, can you confirm that you can see my screen? For the new members, we do have another like a premium group in which we discuss on. So the premium guys, can somebody write me please? Can you hear me? Okay, good. So let's start this. So today we are going to finish up what we have left from microbiology gram-positive bacteria only. So the previous class we started to describe all of the cocci, what do they mean. We described also different biochemical testing to differentiate between different cocci. For today, we are going to speak about the rest of the gram-positive organism that we have. So if you remember previous time, I told you that there was only one organism to be a gram-positive organism. Yeah? What was it? A gram-positive coagulase-positive organism. Which organism is the only organism to be coagulase positive? Staph aureus, you are absolutely correct. Good. So my next question is, do you remember if an organism tests positive for an H2S agar? You remember we spoke about something called the H2S agar, and I told you when it's positive, first of all, what will be the color? Which color it will give? H2S agar. Black, it will be black. H2S agar will be black. And when it will be black, what does it mean? It means that the organism is motile. It can move, okay? So let me just send you this really quick. Yep. So as you can see here, the organism, when we put it in the H2S agar, since it's motile, it will give a black color. Okay, so also you can see it here giving a black color, and this is a way of the many ways we can use for the diagnosis. Yeah, so here you go. Okay, so next thing next. Today we are going to continue speaking about Bacillus Anthracis. Before we speak about anthrax, there was a little point I forgot to mention regarding the Enterococci. There was the TERB, which is a transurethral resection of the prostate, okay? So during transurethral resection of the prostate, we can have contamination and the creation of endocarditis secondary to which form of bacteria? Can you remind me, please? Which type of bacteria can it be? Enterococci, absolutely correct. So you need to know what is TERB. TERB is, yes. So that will be Enterococci. So this Enterococci can contaminate it, and then they can go into the circulation, which can lead to endocarditis. Yep, super high yield concept. Okay, please be careful because this Enterococcus faecalis is resistant even against vancomycin. And to treat it, does anybody know which antibiotic do we use for Enterococci? So for Enterococci, if you remember the sketchy that I told you to watch, they had this lion and they had this tiger. So you are completely correct. Linezolid and tigracycline. So tiger, tigracycline, and linezolid. Yep. You can see he's resisting going into the van. So it's vancomycin resistant. And see here, do you love nature? The U here represent the UTIs. The heart is the basically the endocarditis that it can precipitate to, and the trees is green, which represents the biliary tract infection. Yep. Remember, it's resistance, and you can even see that it can grow in 6.5% basically agar, in which this we consider it to be hypo, normal, or hypertonic. What is this considered to be? Hypertonic. Excellent. It's hypertonic. Okay, good. So the next thing I want to speak about, I just wanted to mention this thing about Enterococci because it's really important. So the Bacillus Anthracis. If we speak about anthrax, where can we find anthrax normally in the nature without human involvement? Can we find anthrax normally in the nature? Yes, you can find it in the sheep. Well, is it in the meat of the sheep or where exactly? Yep. So it's in the sheep wool, basically, this thing. You can find anthrax. Also, you can find it in the soil. It's possible. But there is a little twist to this. So if we speak about anthrax and we find it in the wool, I want you guys to know one thing about this. This can lead to cutaneous anthrax, not the pulmonary one, okay? So this mostly lead to the cutaneous anthrax, okay? Which affect the skin. If we speak about the pulmonary one, it's mostly in bioterrorism, basically. It is not for coming from animal. So this is important. If we speak about the one comes from the wool of the animals, it can lead to this. Guys, do you know which country has a lot of cutaneous anthrax cases? This is important because they ask it on the step. They will tell you this person is from that country. Not really. It's China. It's China. Okay. So well, I don't know why, but apparently Chinese sheep are full with anthrax and corona. So yeah. So basically, it will be like a sheep from China. The next thing we are going to speak about is the following. So we studied the Bacillus Anthracis. First of all, we know that it's a gram-positive. We saw that in Sketchy. It's a spore-forming rod that produces anthrax toxin. Okay, this anthrax toxin, actually, it's not one toxin. It's a couple of toxins. He has the following like subtypes. So they write an exotoxin consisting of a protective antigen. And a lethal factor and an edema factor. If we mention the edema factor and the lethal factor, we need to understand what is the difference between them and what do they mean. So, if we speak about the edema factor, it increases something called cyclic AMP. And cyclic AMP increase can lead to what? Cyclic AMP is working over time. That will lead to more chloride going into the interstitium, more sodium into the interstitium, lead to more, leading to edema. Absolutely correct. So, in case of the anthrax, please know that it can lead to edema. So the question comes, where the edema is exactly in this lesion? This is due to cutaneous anthrax. Where is the edema? Is it in the central or in the peripheral? Yep, the red area, which is around it. So it's peripheral. Okay, so the area in the around, if they give you an arrow question, they give you an arrow about this red area, and they ask you what is the cause. Is it the lethal factor or the edema factor? You will tell. Yep, absolutely correct. It is the edema factor. And if they ask you, is it due to cyclic AMP increase or cyclic GMP, you will say? Absolutely correct. Cyclic AMP. Good. So let me send you this. This is a cutaneous anthrax. The next thing I want you to know about anthrax is Yep. Guys, I hope you know what is this medusa. Yeah, the medusa like in the sea. On the culture of anthrax, you can see a medusa-like shape, and they do ask about this. They can show you a culture and ask you, what is this? So the moment you see medusa, remember about anthrax, okay? So this is just the gross culture, that's it. It's not a histological finding yet. So here you go. This is the medusa. Please somebody tag it with anthrax. And the next things that you can see is on histology. In histology, it's a rod. We all agreed that it's a rod, which means like a bacillus, but it has something really characteristic of it. It has, let me just find it. Yes, this is it. Okay, so first of all, guys, what are these round-like structure? Can somebody tell me what are these round-like structure? Rod in chains, correct. It's rod in chains. And the little round structure are actually the spores of the anthrax. Yeah, these are the spores. And we know that anthrax is a spore forming. So the spores will be here and then they will be detached and released into the local area. You also can see here, I always imagine anthrax to be a train. And this train is coming to hit you. So anthrax is a train. And it has endospores inside of them. And they describe it as rods and chains. That's correct. Good. The next thing we are going to speak about, oh yeah, look at this perfect image. If you see this guy on the left, you can see the necrotic factor affection, absolutely correct, and you can see the red stuff. Now comes the logical question, what is this? What are they showing on the X-ray? Why there is an X-ray in the question about anthrax? Yeah, why there? Somebody is writing wide mediastinum. I agree, they have wide mediastinum, but why? Why people with pulmonary anthrax? So we are done with cutaneous. Now pulmonary. Pulmonary anthrax have widened mediastinum because of the hemorrhage. They will have hemorrhagic mediastinitis, okay? So they will have a lot of bleeding inside of their mediastinum. Basically, this is blood. And they will have something like this. So a logical question will be, how can I take a look at a mediastinum and where is this mediastinum? What does it mean? And how can I know that it's widened? First of all, you need to know how a normal mediastinum looks like. Normal mediastinum looks something like this. So you can see the heart is making 2/3 of the space, and always the lower portion of the heart is much smaller in diameter than the upper portion of the heart. If you take a look at the chest and it's wider from the top as it's wide from the bottom, this is a wide mediastinum, okay? So basically, if you see this aortic knob here, there is an aortic knob, yeah? Can you see it here? No way, it's disappearing because of the hemorrhagic mediastinitis. So let me send this photo and let me show you a normal mediastinum. So what is a mediastinum? First of all, it's an area, it's a basically an anatomical area located between the lungs. And it contains many organs inside of it. It contains our heart, our thymus, many structures exist in the mediastinum. So if we imagine that we have our left lung here, right lung here, right lung here, the area in between these two structures, we call it the mediastinum. So it is something like this. Yeah, this will be the mediastinum. It has some portions that I don't want you to know about. I will ask you about them later. So again, these patients will have widened mediastinum. For those who did cardiology with me, do you remember what other cause of widened mediastinum we had? There was another cause of widened mediastinum. Do you remember it? Well, cardiomegaly, it might lead to it, but there was something else. Tamponade, excellent. What else? Except tamponade, what else can lead to wide mediastinum? If you remember, we also spoke about like these aneurysms, and if an aneurysm rupture, what is going to happen to the patient? Basically, boom. So that can lead to widened mediastinum. And also in case of aortic dissection, yeah? So aortic dissection can also lead to widened mediastinum. So this is aortic dissection, widened mediastinum, and let's say aortic aneurysm, rupture, it looks exactly the same. And let's say anthrax, it looks exactly the same. So how can I differentiate between the two, between the 3 or 4? All of them by the same way, clinical scenario. So this is just a finding. This is symptoms, it's not a diagnosis, okay? Oh, good thing I was recording. I thought I was not. Okay, so if you remember in the sketchy, they mentioned about anthrax few stuff. They mentioned the lethal factor leading to the necrosis, edema factor leading to the edema, and they mentioned that it has a polypeptide capsule. Guys, is peptide sugar or a protein? Proteins. So what makes proteins? What makes proteins? Amino acids. Absolutely correct. So these amino acids, when they come together, they make a protein. For example, this Bacillus anthrax. And I have a really important question. Is it typical for bacteria to have a protein type of capsule? No, it's not typical. That's correct. It's not typical. So normally, what type of, what it should be? Yep, it's really sweet. It will be polysaccharide. Yes, sugar. Correct. So, so you said it composed of amino acid, this polypeptide. And this polypeptide basically is the glutamate. What is the glutamate? It's a type of amino acid, glutamic acid basically. So if we just take a look here and Google polyglutamic capsule, it has this weird structure that it's not required from you. You don't have to know it. You don't need to know anything about, except that it exists. And it has this poly D's inside of it. Okay? That's it. So you can see D-glun. You don't need to know exactly what it means. It's just a chemical structure. That's it. So if we watch the sketchy, they made it in a really good way, actually. Yeah. So if you remember D, poly D. So that was the anthrax. Yep. Okay. So the next thing is the following. The colonies show a halo of projections, which was the Medusa head. Remember the white colonies I showed you? Sometimes referred to as the Medusa head appearance. So if you remember, I showed you this picture. I sent you this picture. See, this is the Medusa head. Yeah? So please somebody write, you need to name it. I don't know how to do that, but yeah, Medusa head. And it's anthrax. Okay? Okay, good. So the next thing is regarding the cutaneous versus the pulmonary anthrax. Guys, which one of the two do you think is more fatal and can kill the patient? The pulmonary, absolutely correct. Which one is more common? More common. Cutaneous. So cutaneous anthrax will lead to a painless papule surrounded by vesicles. Now the question will come, why it's painless? Well, this tissue, the black one, is it live or dead? It's dead. Can a dead tissue have any sensation? Nope. So they cannot feel any pain. This is a good time to speak about diabetic foot actually. In case of diabetic foot, that is really bad shaped actually. Something like the, what? Diabetic, no, foot, not food. Diabetic foot. So, okay, so you can see sometimes they can have really bad gangrene in which you practically can see their bones. Something like this. So is this painful or painless? Painless. Look, it looks ridiculously disgusting and it looks horribly painful. But since it's necrotic, they will not feel anything. So it looks something like this. It looks practically fake, but it's painless. Yep, it's painless. Remember guys, anytime you have a necrotic tissue, it's painless, okay? So let's go to the next thing. Here is the thing, because of the peripheral neuropathy, they cannot feel anything actually. And in the first part, what they got it in the first part, because they keep hitting their legs, and causing mechanical trauma of their legs. And to give you a tip for diagnosis, which will be helping you both in the USMLE and in real life. If we imagine that this is a foot, and then they give you a lesion here. Let me make the lesion in red. If they give you, the lesion is located here, in the tips of the finger. And you have option number 1, arterial insufficiency. Option number 2, venous insufficiency. Option number 3, diabetic foot. So if the lesion was here, what you will choose? 1, 2, 3, arterial insufficiency, venous insufficiency, diabetic foot. It is not diabetes. No, it's not diabetes. It's arterial insufficiency. If you have decreased blood flow to the leg, the area that will be affected the most is the area that will be the most distal. So in case of arterial insufficiency, the lesions will be at the tip of the fingers, okay? So if we take a look here, I will tell you. Well, if you take a look at arterial insufficiency foot, the lesion will be at the tip of the fingers, okay? At the distalmost portion of the finger, okay? Because it's basically a watershed area, the last area to be affected, yes? So, okay, you are like, okay, I'm fine with this. This is peripheral arterial disease. The most affected part will be the distalmost portion. What about diabetes patient? Let's take a look again. So I give you the same picture. Just, I know my drawing is bad, but can you just imagine that this is the lower portion of the foot? It's like you are looking at the foot from down, okay? If we imagine that this is the foot, you are looking at it from here. And they tell you the lesion is here. Which disease is it? The primary lesion, the beginning lesion was here, which is like, the sole of your foot. This is diabetes. This is diabetes, okay? So this is diabetes, and you are like, logically question, why? So why is really important question, because we keep hitting our lower portion of our leg here, yes? And when we keep hitting when we keep hitting that area, it can lead to what? It can lead to, this one. See? This is the primary lesion, guys. So it starts from here. As you can see, their fingers is fine. So it starts from here and then spread. Arterial insufficiency, it starts from the toes. These concepts are super important. I cannot tell you, guys, how much they are important, because you will see actual question on them. So this is diabetic foot, basically the beginning of diabetic foot. Basically because you keep hitting it, they will get this lesion and it will start to go bigger. Now I will ask you, is it painful? Nope, it's not. Okay, here you go. So the last one is venous insufficiency. In case of venous insufficiency, the lesion will be at the medial and lateral malleus. So you are like, malleus? What is malleus? Malleus is a prominent bone lesion. Just a second. Let's take a look at the ulcer. Yep. Oh yeah. It will start here. Now a logical question, why in case of venous insufficiency the lesion is here and not at the tip of the finger? Well, I will be telling you it's gravity mediated. So you'll be like, wait a second, man, that won't cut it, you know? Okay, I get it, like veins and all of that, and the veins drain down there. But why it's not in the foot? It's a little bit above the foot, you know? It's because of the distribution of the veins. If you take a look here, let's say in venous insufficiency, the blockage was here. So all of the blood will go down to the area where everything goes back to. All of the veins from your leg will go back to this area. all of the veins from the side of your legs will go back to this area. What is the name of this area? We call it the malleus, okay? So, because all of the blood, it drains back to that area, it's malleus. I hope you are comfortable with differentiating arterial versus venous versus diabetic foot ulcers. It's super important for both your clinical life and for your exams. So, oh yeah, we went for that for no reason. Okay, so painless papules surrounded by vesicles, so they will have this ulcer with a black scar. It's painless and necrotic. Uncommonly progresses to bacteremia and death. Why? Because this lesion, well, it can lead to some other opportunistic bacteria to enter your body, leading to sepsis. Yeah? And in case of septic shock, what happens to the cardiac output? Come on. Somebody tell me what happens to cardiac output. High. Excellent. It will be high. And what about the systemic vascular resistant? Down. Absolutely correct. Down. Yep. Low. Okay, so now pulmonary anthrax, which is highly fatal. Okay, inhalation of spores is the cause. Yep. And the most commonly from contaminated animals or animal product. Also, it's a potential of bioweapon. And that's how the question will come. Guys, how fatal is pulmonary anthrax? If you can give me a percentage from 1 to 100%, how much you will give me? Yep, actually, from everybody who got it, only one man survived. Like in the US, there was a documented 60 cases of it. Only one guy survived. So it's around 100%. Even the guy who survived, he's still suffering from symptoms until this day. So flu-like symptoms that rapidly progresses to fever, okay? It progresses to fever. And pulmonary hemorrhage. So you must know it's a hemorrhagic mediastinitis with a widened mediastinum on a chest X-ray as we saw. And it can lead to shock. So it's also called the wool sorter disease. We said that it comes from the wool, but mostly the wool will give you the cutaneous anthrax, not the pulmonary anthrax. Okay, well, you can use for prophylaxis ciprofloxacin and doxycycline when exposed. So if you suspected an exposure but you don't have symptoms, you start this. What if you have symptoms already? You will start this, but it's too late. It's too late. If you start having symptoms, the patient is dead. Okay? So that's pulmonary anthrax. Guys, by the way, if you have a case of anthrax, you must report it or not. We don't have antitoxins. We don't have anything for it. No. You must report it. Do you know any other disease that you must report for the CDC? Smallpox, absolutely correct. What about measles? You need to report measles as well. What about TB? Yes, excellent. TB, you must report TB. Leprosy? Yes, you must report it to CDC. So CDC is an organization in the US. It's for disease control, okay? So these guys, basically their main function is to check where is the problem. Okay, let's do isolation, prevent spread. These guys are much well equipped than anybody else, you know? So they know, basically the taxpayers spend a lot of money on them. So they can do their job better than anybody else. So you must report for them. Okay, a really quick ethic question. If you have a guy who has HIV, don't want to tell his wife, what you should do? Yep. Oh yeah. So if someone has HIV and you must report it to the CDC. Okay, the next step, the CDC will call his wife and she will be like, what of the following conversation will happen? 1. Hello, your husband has HIV. You need to test yourself. 2. Hello, an intimate partner of yours was tested for HIV. You need to get yourself checked. The answer is 2. Because you never say the identity of the patient. you need to protect his identity, but if she only has one intimate partner, it's exposed. So it's logical. So, okay. So done with this page, let's speak about Bacillus Syrus. Bacillus Syrus is a gram-positive rod that causes food poisoning. And the spores survive after cooking rice, especially in case of reheated rice syndrome. So what is this idea of reheated rice? Basically, in some cultures, they have this food as like not cooked rice, but fried rice. They fry the rice. Well, the problem is not with the frying. The problem that after frying, they can eat it, no problem. But they leave it sitting in there and then they eat it. Who loves to relax a little bit after cooking so he will have time to germinate? Who needs some time to germinate after cooking? Spores. The spores. Yep. So the spores of the Bacillus Syrus will start germinating. So they survive cooking rice, reheated rice syndrome. If you remember when we spoke about the spores, I told you how resistant they are. So keeping rice warm results in germination of spores and enterotoxin formation. This toxin is super serious. Why? Because it can lead to really acute symptoms. But I have a question. Will you die from it? No, you will not die from it. It starts really quick and it goes away really quick. So, most common type is actually the emetic type. Okay? Yes, it's self-limiting. Most common type is the emetic type, in which they eat this thing, they eat the rice, and they have this ridiculous amount of vomiting. You must know which substance is leading to the toxicity. Obviously the toxin, but you need to know the name of the toxin, okay? So it's Bacillus Syrus. So the toxin name is Syrolid. Syrolid. Please know the name. It's Syrolid. So, emetic cause, and it can lead to nausea and vomiting within 1 to 5 hours after consumption, and it's because of a preformed toxins as well. So I have a question, guys. How can I differentiate between this guy and Staphylococcus aureus one? Because both of them led to a quick type of like food poisoning that resolved alone. How can I differentiate between the two? History of the food, you are absolutely correct. So if we speak about Staphylococcus aureus, it was mayonnaise, it was meat, it was what else except mayo and meat? Mayo, meat, custard as well. Okay, custard as well. But if we speak about Bacillus Syrus, it was only the rice. That was the rice. Okay, good. So diarrheal types causes watery, non-bloody diarrhea and a GI pain within 8 to 16 hours. So the diarrheal one takes a little bit of time. If you want to ask me why, it's until it reaches the intestine. You need kind of 8 hours until you reach the small intestine. But the vomiting one, it's until it reaches the stomach, which is take less than an hour. So anyway, both of these is just supportive treatment, and you need to give them a lot of oral rehydration therapy. Antibiotics are ineffective against the toxin. Well, the Bacillus Syrus, what is leading to the toxicity? Is it the Syrolide or is it the Bacillus Syrus? It's the Syrolide. Thus, it's a toxin-mediated type of diarrhea. Now comes my next question, which will answer your question. The Syrolide, it is increasing the cyclic AMP. Is it destroying the intestinal cells? Yes or no? Is it destroying the intestinal cells? It is not destroying the intestinal cells. If it's not destroying the intestinal cells, will you have watery or a bloody diarrhea? Absolutely correct. You have a watery diarrhea. Good. Guys, just like an overall concept, if you destroy the epithelial cells of the intestine, it's bloody. If you don't, it's watery. Okay? So, if I'm speaking about Giardia, for example, and it's just like blocking the intestinal microvilli, but it's not actually destroying the epithelial cells. Will it be watery or bloody? Yeah, watery. If I'm speaking about Shigella actually destroys the epithelial cells of the intestine. So it will be bloody. So that's the idea to differentiate between the two. Is it destroying the epithelial cells or not? Destroy, bloody. Not destroy, watery. Done. Okay, good. So now let's take a little break and then we'll come back, speak about the Clostridia, Corynebacterium, and Listeria, and keep going today until we reach the gram-negative bacteria. That's our task for today. So see you guys in 9 minutes. Okay, everybody, welcome back. So let's continue speaking about these bacteria. We have few things I need to finish up speaking about. So first of all, we'll speak about the Clostridia. The Clostridia family is also a gram-positive spore forming. So how do we know that? From Sketchy, yeah? So as we said, for those who missed the previous class, I explained in the previous few classes that we need to do Sketchy, and according to this, we will be giving our class because we compare Sketchy with what we study in the class. This way, we can enhance the ideas that come from Sketchies and basically give you all the ways that you can be asked the question on the real deal. So, the Clostridia are gram-positive, spore-forming, obligate anaerobic rods. Can somebody tell me, please, in Sketchy, how did they represent the anaerobe? Yep, it was the mask. You are absolutely correct. It was the mask. Good. So let's take a look. So yeah, in Sketch Micro, they represented the anaerobes with the mask. Yep, that's super important. Guys, what we are going to learn today is actually pretty high yield. You will at least get 3 to 4 questions from the stuff we are going to speak about today. So the Clostridia tend to be one of the most important things that you must learn overall. Tetanus toxin and botulinum toxin are proteases. So proteases are enzymes that destroys proteins. And if we speak about enzymes in our body, are enzymes proteins or not? Enzymes, are they proteins or not? The enzymes. What is enzyme? Enzymes are mostly proteins, okay? Mostly enzymes are proteins, except a couple of them that we'll speak about in biochem. But in general, enzymes are proteins. So when we speak about the proteases, these are basically some form of enzymes that are able to destroy another enzymes. So they can cleave off something called the Snare Proteins, which are located in the synaptic presynaptic cleft. So let's first of all speak about the synapse. And what is a synapse? A synapse is a connection between two neurons, or like a neuron and a neuron, or a neuron and a muscle, or a neuron and an effector cell. So if we speak that we have first neuron and we have second neuron. They touch each other at this point. This point looks like this. So snare proteins are proteins that are responsible of moving the vesicles, which contains the neurotransmitter from the presynaptic cleft lumen to the presynaptic cleft wall to be released, of course. So these are snare proteins' responsibility. Again, the snare protein responsibility is to move the vesicle inside of the presynaptic cleft into its end junction. Okay? So I hope it makes sense. So let's take a quick look at this. You can see here, you have all of your neurons. Let's look for a synapse. Okay, here is a synapse. Notice, neurotransmitter are going to the presynaptic cleft. Let's go closer. Okay. Now the presynaptic cleft is pushing the neurotransmitter to the outside. Well, how is this happening? Notice, let's go closer to it. Okay, now we are going closer at 1 unit. So this 1 unit has the neurotransmitter inside, and this is the vesicle. And you can see the attachment and then how it's getting pulled and released the neurotransmitter. So before we continue, what are these guys? What are these structures that help the vesicle to release the neurotransmitter? How do we call these? Well, these basically are the snare protein, guys. These are the snare proteins allowing the neurotransmitter to be released, as you can see. So they grab the vesicle and they allow the neurotransmitter to be released. Yes? So if we imagine a patient does not have a snare proteins, can he release his neurotransmitter? Yes or no? He cannot. If he cannot release the neurotransmitter, he will lose some functions or gain some functions according to the type of neurotransmitter. So let's take a look. Exactly. So proteases destroys snare protein which involve in neurotransmission, as we saw in the video. So let's start with the one that I like the most, is Clostridium tetani. To start with, can we prevent it? Yes or no? Can we prevent somebody from getting tetanus? Yes, how? Vaccine. Absolutely correct. Clostridium tetani pathogen is a non-invasive. Wow, he sounds nice. He's not invasive. So how can a non-invasive microorganism lead to a pathology? By making a toxin. Yeah, the toxin. It enters using the trauma, that's correct, but the use of the toxin is the thing leading to the pathology. So their toxin name is titanospasmin, which is an exotoxin causing tetanus. Titanospasmin spread through a retrograde axonal transport to the CNS and block the release of GABA and the glycine from the RAN cells in the spinal cord. Sounds like a lot. Let's take 2 steps back. The first thing I want to speak about is what do they mean of this contamination of this microorganism of the wound. Well, to get tetanus, first of all, you need to get a wound. After that, you need to get the Clostridium tetani, which comes from the soil, okay? So it comes from the soil, like getting a wound and then, or rusty nail. You step in a rusty nail, and here we go. It all starts from that. So let's step on a rusty nail. What's next? After stepping on the rusty nail, the bacteria is going to contaminate it locally. And it will start making spores, you are correct. And after that, it will make titanospasmin. So how can the titanospasmin makes it from the wound to the CNS? Well, it moves inside of the neurons. So it moves inside of the neurons, the toxins, of course, retrogradely. Guys, do you remember what helped you to move retrogradely inside of the CNS? Which molecule helped you to move retrogradely inside of the CNS? If you want a hint, when we spoke about cardiology, it used to help in the lubing of the heart. The dyning arm, you are absolutely correct, the dyning arm. So it takes the help with the dyning arm to move the toxin from the periphery to the CNS. And it moves retrogradely, obviously. Okay, it reached the CNS. And then this titanospasmin will cleave what? It will cleave the snare protein. So when the snare protein are not functional, they will not be releasing these. So now comes the first question. What neuron are they inhibiting? What neurons are we inhibiting, guys? The GABA and what else except the GABA? No, you were correct. Why you deleted it? You are completely correct. GABA and glycine. GABA and glycine. Yep. So our GABA and glycine. Yes, that's for botulinism. The acetylcholine for botulinism. So the GABA and the glycine, are they inhibitory or stimulatory? Okay, so inhibiting an inhibitor, they are inhibitory. Inhibiting an inhibitor will lead to excitement. Absolutely correct. So let me tell you a little bit about something maybe you never heard before. Something called interneurons, okay? So there is a concept called interneurons, and it's related highly to tetanus. So let me show you what I mean by that. Well, inside of your spinal cord, yes. Okay, so inside of your spinal cord, you have this stimulatory neurons that want to go and stimulate the muscles, yeah? By releasing what? Acetylcholine. And there is these neurons, interneurons, that are always inhibiting these neurons using what? What neurotransmitter do we use to inhibit the neurons? What neurotransmitter are we using to inhibit the neurons? GABA and glycine. Yes, GABA and glycine. So when I use the tetanus toxin, look what I'm doing. I am cleaving the snare protein, which will prevent the glycine and the GABA from being released, which prevent the acetylcholine neurons from releasing this acetylcholine. So Normally, this GABA and the glycine prevented the release of acetylcholine. Now, when they are blocked, there will be more release of acetylcholine. If there is more release of acetylcholine, will you have a flaccid paralysis or you will have a spastic paralysis? Spastic, remember, spastic, all of your body is in a spasm position. You are, while a flaccid paralysis, you are totally relaxed. Yeah? So, and this will lead to spastic paralysis. Two notes. First of all, these ones who release the glycine and the GABA are called inhibitory interneurons. This is the first note. The second note, I'm trying to find their location. I cannot find it, so I will tell you exactly where they are. They are located in the spinal cord. Okay, guys? So they are located in the spinal cord. I cannot find an exact picture of them, but oh yeah, here they are. See, this is the Rancha cells. They are located in the spinal cord. Finally, I found it. Here you go. So, if you get a picture, where is the tetanus doing its problem? It's here, okay? Good. So, let's keep going. And they write, that's the Ranch cells in the spinal cord, the same as saying the interneuron. Okay, so they lead to few problems. One of the problems that they can do is a spastic paralysis. So this is spastic paralysis. You get why? Because you don't have inhibitory neurotransmitter anymore. And also they can lead to something called locked jaw, which is the trismus, which will lead basically to serious problem in you eating. It will be really difficult for you to eat. Why? Because you cannot open your jaw. You tell this patient, open your jaw for me, please, and they are doing something like this. That's not good. Yep, that's a locked jaw. That's a locked jaw. Okay, the next thing that we have is something called rhesus sardonicus, which is a type of laugh. Okay, it's evil. Yep, it reminds me of my childhood for a reason. Okay, take a look. So they are smiling a lot. Yep, happily ever after. No, this is fake. Just a second. Yeah, this is true. Okay. So you can see rhesus sardonicus. They also mentioned that it's like an evil laugh. I don't think it's an evil laugh. I think it's a suffering laugh. So yeah, that's rhesus sardonicus. Please note. Why it's happening? Because of the spasm. So the last thing and the last symptoms that we will discuss is ipsitonus. I will tell you what it is, and I will tell you why it has this weird name actually. So, it's this guy. So it looks like something like this, and you can see this guy in the hospital having something like it. So, so back at the Greek time, they used to show something like this, which is okay. This is tetanus, but why it's related? It was a way to make a man suffer. It's a way for torturing. Putting a person in an ipsitonus position was to grab his legs and connect him with his arms and to keep him like that for a long period of time. So that's where the word ipsitonus came from actually. And it's also it looks like a structure that we'll speak about later. But in general, I want you to know that it just looked like this, ipsitonus, okay? Yep, something like this. Okay, done with tetanus. Tetanus is tetanic paralysis. Prevent with tetanus vaccine. Guys, I took the tetanus vaccine last time in, I don't know, 3 years ago. Should I get revaccinated now? I should not? Well, how often do we give the tetanus vaccine? Yep, every 10 years. You need to get it every 10 years. Good. So, prevent with tetanus vaccine, treat with antitoxin, positive or negative vaccine booster. Also, so yeah, you can use antitoxins in case of tetany. What about in case of anthrax? Can you use antitoxins in case of anthrax? Will they work? They will not work. They are completely useless. He's dead. So, you need to give vaccine booster every 10 years. Antibiotic, you do give these, but keep in mind the pathology is because of the toxin, not because of the bacteria itself. Why we give diazepam? They are in a spastic situation. Diazepam lead to muscle relaxation and wound debridement to reduce the load of the bacteria. Okay, that was all about Clostridium tetani. I assure you guys, you will get at least 1 to 2 questions about the Clostridium tetani and the Clostridium botulinism. Master these topics. The next bacteria is the Clostridium botulinism. In the Clostridium botulinism, they produce a heat labile toxin. When I say heat labile, if I cook a food with the Clostridium botulinism toxin, will it destroy the toxin or not? Heat labile. It will destroy the toxin. Remember, heat labile will destroy. Heat stable will not destroy. Label, destroy. Stable, cannot destroy. He's stable to the heat. You cannot destroy him. Okay? So, that inhibit the acetylcholine release at the neurotransmitter junction, causing botulinism. Okay, so what we are inhibiting now? Acetylcholine. Now a question, acetylcholine for the muscle, is it stimulatory or inhibitory? It's a stimulatory, so if it's destroyed, what will happen to the patient? Will he get a spastic or a flaccid paralysis? Spastic or a flaccid paralysis, absolutely correct. Okay, good. So, in babies, ingestion of the spores in honey lead to disease, floppy baby syndrome. While in adults, disease is caused by ingestion of the preformed toxins in canned food, for example. Okay? So it can be in the canned food, for example. So this is super serious. The canned food, you need to be really careful actually. This is also for your real life. Which can you don't buy? When you go to the supermarket and you see one can, if you see something on it, don't buy it. Yep, the one with a lot of gas in it, the inflated one. If you see it much bigger than it should be, don't buy that. It probably has botulinism in it. Okay, what other... oh yeah, this is a way to test it. You can just press on it, you know? If it presses back, like it has air in it, this one, this you throw in the garbage right away, okay? But mostly actually it happens from food-borne home, okay? That's the most important. Like they make something like this at home and it happens because of it. Now, okay, if you have something like this and then you cook it really, really, really good, will you still get botulinism, yes or no? You will not. You will not. Good, because it's heat labile. Okay, good. So, they write, in babies, ingestion of the spores in honey can lead to the disease. But in adults, it must be toxin. So in babies, it's the spores. In adult, it's the toxin. I'm an adult. Why it's okay for me to eat the spores? Why the spores cannot give me the disease? You are absolutely correct. Because there is, as an adult, I have a lot of bacteria in my colon. So this colonization of bacteria inside of my colon will prevent, if this is the colon, there is a lot of bacteria, normal flora, which will be fighting with the spores and will not allow them to germinate. There is no free place. It's either for us or for you. So that fighting between the two will lead to no Clostridium botulinism spores to germinate at that area. Okay? Good. So, yeah. And they exist in honey. So you should not give honey for babies until which age? 1 year old. Absolutely correct. Yeah. So I want to give you two scenarios really quick before I forget about them. The first scenario about the Clostridium tetani. You know, when you clamp the umbilical cord, you know, you have the placenta, you have the umbilical cord coming out of it, and it goes to the baby. Yes? When you clamp this, in some culture, they put sand and dirt from the ground on it. Okay? Like for homeostasis type of thing, and to stop the bleeding, and to make the child attached to his home country, and all of that stuff. So, patriotism type of thing. Well, anyway, we respect all cultures, but the main idea, you need to be careful because it can lead to toxin. So basically, when you cut this and you put dirt on it, the dirt can have a Clostridium tetani, which can give tetanus to the baby. So if you have that scenario, just make it click in your brain about tetanus. The other way is about like also a cultural type of a question. In some communities, it's a traditional to give honey with milk to the baby, okay? So also be careful about that because that can lead to Clostridium Butyluminism, okay? So these are the two culturally related diseases of the newborn. Okay, guys, does anybody, before I forget as well, since we are speaking about cultural disease, does anybody of you know what is the HAD syndrome? The HAD syndrome. No idea? The HAD syndrome? No. Okay, well, I will give you the scenario and I will want you to give me the answer. I will give you options. A patient comes to you, 22-year-old guy come to you. He is from an Eastern country, East Asia, and they tell you that this guy is telling you that he loses sperms in his urine, okay? And he tell you that he thinks that this is a really USMLE question actually. He's losing sperm in his urine. And he's afraid to go to the toilet anymore because he's losing so much sperm in his urine that he thinks that he's soon becoming infertile, you know? And he also feels really guilty because he masturbates and he says that his reservoir of sperm is almost done. How do you manage such patient? 1. Refer him to psychiatry. 2. Investigate the patient cultural belief. 3. Ask the patient what he knows about the physiology of the sperms and how they are made and how they go out from the body. Which answer is correct? No, don't refer him to psychiatry. It's the HAD syndrome. The HAD syndrome. 2. You need to ask the patient about his cultural belief because in countries such as India, Pakistan, Afghanistan, and many other Eastern countries, they have this belief that when they masturbate or when they urinate a lot, they lose their reservoir of sperms. It's just a cultural belief, you know? So it's completely incorrect. But if they as a community believe in it, you cannot say that he's crazy. The moment he was born, and since he grew up as a child, he had this, you know, he had this idea. So he's not crazy. He just believes in something that his whole community believes in. And that is the HAD syndrome, okay? So please know about it. Yeah. So these patients can have serious psychological disorder, which can end up with them like having premature ejaculation. They can have this impotence. They can not even be able to maintain erection, which is super serious. As you can see, it has cultural and social factors leading to it. In addition to some anxiety and depression, all comes together, it destroys the life of the patient. So see, he thinks he's losing sperm, he becomes afraid, and he starts having somatic symptoms. So please know about this syndrome. It's asked on the USMLE step 1. So, okay, the next thing. Okay, so now we have destruction of the stimulatory neurotransmitter, which can lead to floppy baby, yeah? So in adult, the disease is caused by the preformed toxins in canned food. So symptoms of botulinism are diplopia. Why? Because your eye muscles are weak. Which is dysarthria. Like the patient will be speaking, but his articulation of the word will not make sense. So he will be reading like this. Toxin. Acetylcholine. You will not make sense of what he's reading. He will just be hearing words. And dysphagia. Why? Because they cannot swallow. Their swallowing muscles are basically screwed. And they have descending flaccid paralysis, which starts in the arms and goes down the leg. Yeah, so start from upper to lower extremity. In which disease we have lower extremity paralysis, then go to the upper extremities. If you don't know it now, it's okay, but you must know it soon. It's Gulab Ray Syndrome. If you don't know it now, it's totally okay, because it happens due to Campylobacter jejuni, which we did not study it yet. Okay, so does not present with sensory deficit, solely muscle. Botulinism is from a bad bottles of food, juice, and honey. So the treatment is a human botulinism immunoglobulin. So you give this immunoglobulin for the patient. It's like an antitoxin. And local botulinism toxin A. Oh, this is important. Guys, Botox. You all know about Botox. So let's speak about Botox. Why Botox make them look younger? Because it paralyzed them. So see the wrinkles, guys? These wrinkles? When you administer Botox, what happens to the muscle in this area? What happens to the muscles if you administer Botox? They paralyze. So when they paralyze, will you have the wrinkles anymore? Nope, you will not. Okay, so will it work forever, or you will have to re-administer it after some time? Re-administer, correct? So it's super serious speaking about Botox, because it's really beneficial. It's not only this cosmetic stuff. There is stuff more serious than this. So it's local botulinism toxin A, Botox injection, are used to treat focal dystonia. Like some people, they have jumpy hand, for example, or their fingers keeps moving, you know. And hyperhidrosis, this is the serious stuff. Exactly, the sweating. You know, some people, you shake hand with them and it feels like there is, I don't know, a lot of water in their hand because they are sweating so much. And regardless of the fact, whatever they do, they keep sweating so much. You try to use any medication on them, nothing works. One thing that you can do is inject them with basically botulinism toxin, which will paralyze their glands, their sweaty glands. But this is good because they will not sweat anymore. But how often should you re-administer the injection? Or should you re-administer the injection or not? The question should be. Or it is a one-time treatment. Yep. You need to repeat it. You need to repeat it often. So re-administration can be as early as in 3 months, but it could be up to 6 months. Okay, also for muscle spasm and cosmetic reduction of facial wrinkles. Okay, done with the Clostridium tetani and botulinism. I assure you guys, you will get 1 to 2 questions about maybe each of these. They love these two concepts. Now, this one is a little bit lower yield, but still, it's important. The Clostridium. Now, a quick question. Is the Clostridium gram-positive or negative? Positive, good. It's a gram-positive organism. So it produces also, this Clostridium perfringens produces a toxin. It's called lysithinase, which is a phospholipase. What our cell wall is made out of? Human cell wall is made out of what? What is it made out of? Our cell walls. Human cell wall. Phospholipid. Yeah, so a lysithinase will destroy the cell wall of our cells. Which cells? All of them. So it's a phospholipase. So if they use alpha toxin, lysithinase, or phospholipase, they are all the same. They can lead to myonecrosis, gas gangrene that presents with soft tissue crepitus. Let me explain about the crepitus because this is high yield. The crepitus, I mean. Clostridium perfringens to start with, I want to show you what does gas gangrene mean. Okay, take a look at this guy. This is a picture of the foot. Can you see this empty structures here and there? There is like empty holes. I hope you can observe these areas. Like there is an area here, there is areas here, 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 here. All of these areas are full with empty spaces with air, yeah? So when you see these areas, yeah, here and here. These areas are gas gangrene, which is bacteria that basically producing gas. She's farting inside of us. So you can see it also here. I hope you can see it. It's in the back of the leg. Yep, it's super serious. So the moment you see this, open, don't think it twice. Open the skin. Yep. So, okay, what about the crepitus? Well, when you click on it, when you push it, when you palpate it, you will be able to hear something like yeah, that's the crepitus basically. Is the crepitus, the pushing of the skin, you will be able to hear like a sound of stepping on an ice. So it will be like yeah, so you will be able to hear the crepitus. Okay, so the crepitus is super important. Oh yeah, and see this wound, is it because of the bacteria or because of the doctor? Who did this? Doctor, of course we did. Why? Because it's anaerobic, so when we expose it to air, what happens to it? The bacteria, I mean. It dies. It's a million times better than an antibiotic. So let's take a look at the next thing. Okay, so they write presents with soft tissue crepitus and hemolysis. If heavily spore contaminated food is cooked but left standing too long at less than 60 degrees, spore will germinate. So let's just make a small line here. This Clostridium perfringens can lead to two pathology. The first one is the myonecrosis, which we spoke about. The second pathology that it can lead to is basically food poisoning, okay? So when does the food poisoning occur? So if you have a lot of spores contaminating the food and it was standing for a long time in a cold environment, 60 degrees is considered cold, the spores will germinate, okay? And it's a heat-labeled enterotoxins and it has late onset, 10 to 12 hours. And it has food poisoning symptoms resolved within 24 hours. To be fair with you guys, they ask about the first pathology, they never ask about the second pathology. Because they want you to know that the cell wall is made out of phospholipid bilayer. Okay, the last disease is super high yield, is Clostridium Difficile. It produces toxin A and toxin B. These toxins have two subunits, A and B. Yeah? They lead to damage of enterocyte. What is the function of unit B, guys? What is the function of the toxin B, which is the binding unit? B for binding, A for action. Okay? B for binding, A for action. So the B binds the toxin. Okay? And wait. Oh, no, I confabulated. Wait a second. Toxin A and toxin B. Toxin A, toxin B. Oh, I've confabulated big time. Okay, so the B toxin acts at the cytoskeleton, exactly to be more exact, at the actin filament, which destroys them. Yeah? What about toxin A? What is the function of toxin A? What is the function of toxin A in case of Clostridium difficile? Yep, it goes to the brush borders. Absolutely correct. And that destruction will lead to diarrhea. Yeah, because you cannot reabsorb anymore. Well, now comes a logical question. Are we destroying epithelial cells? Yes or not? Are we destroying epithelial cells? Initially, we do not destroy them. Initially, yes. If we are initially not destroying them, the diarrhea initially will be watery or bloody? Watery. Good. So it produces toxin A and B, which damages the enterocyte. Both toxins lead to watery diarrhea, and they can lead to formation of a pseudomembranous colitis, which has this shape. I will show you a couple of pictures of it in a moment. It's often secondary to antibiotic use. You must know the antibiotic that cause it, including clindamycin and ampicillin. The most common one to cause it is, let me see somebody who gets it tricked. What is the most common cause of antibiotic-induced Clostridium Difficile? Come on. No, it's not the clindamycin. It's amoxicillin. It's amoxicillin. It's not even written here. Because it's the most commonly used antibiotic overall. It's the most commonly used antibiotic overall. So logically, it will be the one who will cause the Clostridium difficile the most common. This is a step 2 question. So, okay. Often secondary to antibiotic use, especially clindamycin, ampicillin, and cephalosporin. Also fluoroquinolone, and is associated with protein pumps inhibitor. The important stuff is to know the complication, which is toxic megacolon. Toxic megacolon, will the colon be big or small? How big? Big. Yep. Okay. See this? This is a toxic megacolon. Yep. Exactly. So it looks humongous. Yep. I agree. So, poor doctor, he will be like, okay, let's take this anaconda out of this patient. Okay. I have to say, when I saw it first time, I thought it was fake, but no, this is true actually. So, toxic megacolon. The next thing is to speak about is this one. It can lead to ileus, which is basically, what is ileus? An ability to pass a stool, yeah, and chalk. Okay, difficile causes diarrhea. You can diagnose it with PCR or antigen detection, or both. Toxin in stool. So what is the idea of PCR? Is to detect the toxin. Guys, this is important. A lot of students, when they tell you they have the choices, they choose mistakenly the PCR of the. They choose the PCR of the bacteria. This is wrong. The correct answer is to choose the BCR for the. We're choosing the BCR for the toxin. Absolutely correct. Good. So the treatment of such condition will be with oral vancomycin. So this is funny. Why? Because oral vancomycin itself, it can lead to pseudomembranous colitis. But we use a drug that can lead to it to treat it. Okay. So it's oral vancomycin and fedexamycin. I know that this is a horrible question, but you will see it in a new word. What is the mechanism of action of fedexamycin? You must know the mechanism of action. Fedexamycin. Mechanism of action. You must know about this one. So when we speak about fedexamycin, the mechanism of action goes something like this. First of all, just a second, it works on something called the gamma subunit. So this gamma subunit of the what? Basically the RNA polymerase. So You need to know exactly how it works, right? And to proof check it, you always guys need to use Ambus. Please, it works. Oh yeah, here it is. RNA polymerase inhibitor. Write it down, the gamma subunit of it. So let me just send this, the gamma subunit. Okay? Good. So the next thing we are going to speak about, for recurrent cases, you need to consider repeating Breuer regime or fecal microbiota transplant. Now I have a question, guys. This fecal microbiota transplant, where do we get it from? Where do we get the feces? Because you understand, this is just taking feces from someone, giving it to someone. It's getting it from a donor. You know, guys, you can donate the blood, you can donate an organ, you can donate feces if you want. Basically, you can go check up your feces if they have good amount of bacteria, and they can buy it from you to make bills for somebody else to eat and get normal microbiota inside of their intestine. Yep, if you are into that stuff, you can do it. Okay, guys, so let's take now 8 minutes break, come back and finish the next page. And then we'll call it up for today. So see you guys in 8 minutes. So let's take a look. What do we have here? So, question, did we have to do today actinomycetes? Yeah, yesterday I told you guys you have to do everything until this line, which is like until the end of the gram-positive bacteria, all of them. But actually, to be fair, I think we will be able just to finish this, and this today. I don't think I will go into mycobacteria since it's a really long topic and it requests like a lot of attention. So let's speak about Corynebacterium diphtheria. So Corynebacterium diphtheria, is there so many cases right now, or it's kind of rare? It's really rare. Should you report it if you find a case of it? Is it a reportable disease? Yep, it is. Okay, so gram-positive rods occurs in an angular arrangement. It is transmitted via respiratory droplet. That's why you need to report it if you find a case of it. Causes diphtheria via the exotoxin encoded by beta prophages. Beta prophages. You are like, where did we hear about a prophage? About some phages that comes like basically you know what is a phage? Bacteriophage. It's a virus, yeah? Virus transmitting molecular material from one bacteria to another bacteria that leads to basically it forming a new toxin. Yeah? If you remember, it was in the genetic portion of the bacteria when I was speaking with you guys about where it is. Absolutely correct. The transduction. Yep, you are correct. So when we spoke about the transduction, we spoke about specialized transduction in which we can make the bacteria produce a new toxins if a prophage, which is basically like a virus-like structure, can transmit the molecular material from A to B. Yes, it's a transduction. Specialized transduction. So yeah, so it can lead to potent exotoxin that inhibit the protein synthesis. Remember, please, protein synthesis happen by which procedure? Is it a translation or a transcription? Translation. And it's inhibited via the ADP ribosylation of the elongation factor 2. So this elongation factor 2 will be secreted. Why? Because the ADP ribosylation was secretes, which lead to possible necrosis of the pharynx. There is an inability to make normal proteins that maintain life. So the tissue will die. Which tissue? The pharynx, the cardiac tissue, and the CNS tissue. Okay? Symptoms include pseudomembranes. So pseudomembranous pharyngitis. This pseudomembranous pharyngitis, as you can see here, can lead to grayish-white membrane with lymphadenopathy, the bull's neck appearance. Yeah? If you remember that yesterday we saw the bull's neck appearance, it was ridiculously big and it was because of the lymphadenopathy. They can show you a picture of it and literally ask you what is the cause. Lymphadenopathy. Yep. Okay. Toxin dissemination may cause myocarditis, arrhythmia, and neuropathies. Okay? So, it can lead to myocarditis, arrhythmia, and neuropathy. Keep in mind that these are late symptoms. Okay? They are late symptoms. So, the lab diagnosis based on the gram-positive rod with metachromatic granules and the ELEC test for toxins. So let's take a look first of all at this histology of diphtheria. Yep. You can see here the diphtheria and you can see like how it has this granules on its different portions. Yep, it's something like this. The moment you see this, it's highly characteristic of it. Actually, no other bacteria have the exact same thing. So that is a giveaway, basically. The moment you see like this racket shapes, we call it racket shape, by the way, and it is in both sides, done. You have this metachromatic granules on both areas. You have yourself a diagnosis. Yep. Okay, good. So, and there is basically a biochemical test called the ELEC test that can confirm the diagnosis. If you remember, in sketchy, they are represented by a bull licking, yeah? And the toxoid vaccine prevent the diphtheria. Okay, it's a portion of which vaccine? Which big vaccine contained the diphtheria vaccine inside of it? DTB, absolutely correct. So, it's the TTB vaccine. And yeah, Corini is a club-shaped metachromatic granules on loeffler media. So what is that? See the club shape? They mean something like this, guys. Okay, it's like a rackets, basically. Yep. So they can make a black colony in cysteine telluride agar. So I remember that this story about a guy, doctor basically diagnosing someone with diphtheria. And he calls the CDC and they tell them, oh, I found diphtheria. And he's like, oh, telluride? Are you right? Telluride? So the telluride agar with diphtheria looks black. It reminds you guys of which other agar can be black. Which other agar is black? The one for motility, which was H2S. Absolutely correct. Good. So, A, B, C, D, E, F, G, which is like the ADP ribosylation, which was important for inhibiting which process? Elongation factor 2, protein synthesis, translation basically. Beta prophage, which is basically happened by which procedure? Specialized transduction. Good. Corynebacterium diphtheria, elongation factor 2, and the granules that gave the shape of the rackets. And the treatment is with diphtheria antitoxin. Also, you can give erythromycin or even penicillins, okay? So, all of these are in the sketchy. Moving on, I have to tell you guys about Listeria Monocytogenes. Listeria is commonly in which population of people? Who get it the most? Pregnant lady and their children. So Listeria Monocytogenes, I love this one. First of all, why I really like it? Because of its motility. So I wanna show you how motile it is. It likes to dance. So, ready for the dance? Take a look. See? It moves. Quite cool, huh? Yep. So it moves. It's motile. It's super important because it can, even it has this little rockets-like structure that can make it basically jump from one area to another area. Yeah? So if you, just a second, I hope they mention it here. They don't mention the motility part. Oh, they do. They do. Okay, good. So, take a look. See, this is the Listeria Monocytogenes. It makes this little actin fibers behind it to push it forward like a rocket. Okay? So, that helps it to move forward. Can you see? So, it makes this actin-like fibers and that helps to push it forward. And it makes it pass through the cell, like at different types of the cell. It can even allow it to penetrate one cell and enter the next cell by this rocket-like structure. During initial penetration, look what happened. It took some portion of the membrane of the other cells. And now it's in the new cells, so it starts to lose it and initiate the rocket again. Here we go. Fire. Replicate and then fire. And keep moving. Yes? So boom. And keep moving from one cell to another cell until you affect all the body. See, the whole body is affected. Who are these? Guys, cells with the 3 nucleus. What are we thinking about? Which cell has the 3 nucleus? These are neutrophils, okay? So the neutrophil comes and destroy the whole cell because they cannot destroy one portion of the cell. They have to destroy everything. So, okay, that was Listeria. Gram-positive facultative intracellular road. Why facultative? Because they can move from in out. Acquired by ingestion of unpasteurized dairy product, which is milk, and called deli meat. It has a transplacental transmission by vaginal transmission during birth. It grows well at refrigeration temperature. Like if you put it in the fridge, you will be like, well, okay, I can still grow. I don't really care. And that means you can get it even from ice cream. Yep. So it has formation of this rocket tails. I hope you understood what this rocket tails. Basically, this is the bacteria and this is its rocket tail. Yeah? Via actin polymerization that allows intracellular movement and cell-to-cell spread, as we just saw, across the cell membrane, thereby avoiding the antibodies. Can antibodies do anything to it when it's inside of the cell? Not really. So, yeah. Thereby avoiding the antibodies. Characteristic tumbling motility on the broth. The thing that I showed you in the beginning, it was jumping inside of the broth. So they can lead to amniotis, which is inflammation of the amniotic sac, septicemia, which is basically sepsis, and spontaneous abortion in pregnant ladies. It also can lead to granulomatous infecta septica. They will mention for you an infant who either born or died in utero, it doesn't really matter, but the child that you have now, he has granulomas everywhere in his body. In his lung, in his brain, it doesn't matter. They are everywhere. They can affect also his skin, and they will tell you that in histology they see giant cells. The moment you hear this word giant cells, think Listeria, okay? So meningitis in immunocompromised patient as well, and the neonates and in older adults. It's mostly mild, self-limited gastroenteritis in healthy adults, but the infanta septica, this is deadly. Granulomatosis infanta septica, this is deadly. The treatment is with ampicillin, okay? You must know the treatment is ampicillin. Guys, what is the difference between amoxicillin and ampicillin? It's how you give it. Ampicillin is IV, amoxicillin is oral, okay? Ampicillin is IV, amoxicillin is oral. Otherwise, they act exactly the same. Okay, guys, so I want to actually call it off now because like I got a few messages that you did not prepare this for today, but a disclaimer for tomorrow, please prepare nocardia versus actinomycetes, mycobacterium, both of them, and I will be explaining this whole big graph tomorrow, and will be explaining, let me tell you, Neisseria, Haemophilus influenza, Borrelia burgdorferi or Bissabaceae, this is new in the book by the way, and Bordetella pertussis and the Brucella and Legionella and the Pseudomonas. And even we'll be speaking about Salmonella versus Shigella. You'll be like, what? That needs a lot of time to prepare all of these from sketchy. I agree. And tomorrow is a free day, so you have a lot to do in your free day. Enjoy your weekend. So, see you guys tomorrow, and we will continue tomorrow. Not tomorrow, the day after tomorrow, as always. So I will send you the